To the JOWMA Teen Health webinar on back to school. It's nice to have everyone here with us. So I am Dr. Jackie Benayoun. I'm a pediatric resident at Westchester Medical Center, and I'm going to be the moderator today. I want to introduce the JOWMA Teen Health Committee. JOWMA in general stands for the Jewish Orthodox Women's Medical Association. We're a nonprofit organization whose membership includes Jewish Orthodox female physicians and trainees. Our goal is to provide evidence-based preventative health and women's health education to the Orthodox community. Today, we're going to be addressing the topic of educating teenage girls about going back to school, and we'll cover an array of topics, including mental health, vaccines, and reproductive health. This webinar is aimed at taking a religious teenage girl through her well child visit at the doctor's office. Before I introduce our first speaker, I would like to inform you that we will have a question and answer session at the very end after all the panelists are finished presenting. All questions should be posted in the question box. If you would like your questions to remain anonymous, please hit the Remain Anonymous button. There will be no option to post in the chat box. You should just defer to the question and answer box. If you notice that any other person's response is being anonymous, that's something, sorry, I apologize. You can notice that everyone on the webinar is anonymous. You can only see the panelists. So none of the attendees can see you. They can only see panelists. And again, if you want to remain anonymous when asking a question, there is an option to click a Remain Anonymous button. So for our first speaker, we have Dr. Gail Gutman. Dr. Gutman is a board certified pediatrician. She's currently a fellow in adolescent medicine at North Shore LIJ Cohen's Children's Medical Center. She is a doctor for teenagers, essentially. Dr. Gutman also serves as the co-chair of the JOWMA Teen Health Committee. Some of her side hobbies include running. She's actually finished 5 full marathons, several half marathons, and 1 triathlon. So without further ado, Dr. Gutman, please go ahead and screen share.
Thank you. Hi, everyone. I'm so excited to be here. I'm so excited that all of you are here. Please enter questions into the chat or into the Q&A, and we're so excited that you're here. Okay, share screen. All right, can everyone see my slides? Jackie, you can see my slides? Great. All right, so this is our back to school for teenage girls webinar. So nothing to disclose. You know, the things that I want to address with you today are what you can expect at the well child visit. So I know that all of you take your kids, and you know, next week we're going to be talking about boys, but I know that all of you take your kids to see the doctor at least once a year, or at least that's the recommendation. And even though you've probably been doing it for many, many years, and you know, it's not necessarily so new at this point, I want to go through what you can expect, what as the doctor, what we're kind of looking for, and what is important for us. And then I want to address certain things that come up very often, for example, mental health and school forms, physical, like sports participation, confidentiality, things like that. All right, so first of all, I'm going to kind of take you through the visit. What are the things that happen when you come into the doctor's office and you're about to see the doctor? But before you see the doctor, you probably, unless you're, you know, if you're in a private clinic, it might be that the doctor does these things. But oftentimes the doc, like a medical assistant or a nurse or what's called a PCA, like a patient care associate, will do what's called vital signs. So that is things like taking the blood pressure and the pulse, things like taking the patient's height and weight, and then also we'll traditionally look for like an eye exam. So I just want to make a few points about this. First of all, blood pressure. kids have different blood pressures than adults. So, and actually the way that we determine if blood pressure is high or low is different for kids than it is for adults. So you might see a blood pressure on your child that seems a little bit low, and that actually is normal for this child. So it depends on height. It really depends on the age of the child and on the height of the child. So always ask your doctor, you know, or ask your child's pediatrician if you're worried about the blood pressure, but you just know that it's not necessarily the same as what it is for you. The other thing that we look at is the pulse. Kids who are very athletic, who might play a lot of sports, they might have lower heart rates, and that can be normal. It can also be a sign of malnutrition or of low body weight. So that is something that we look for. In terms of weight, so a lot of people, if you came to our body image webinar a couple months ago, you know, a lot of people will recommend that you offer your child what's called the blind weight, where the child won't see the number. There's a lot of differing opinions on this. As a pediatrician and as a doctor, I do not advocate for that. I think it's important that a kid knows his weight. I think it's a vital sign, just like anything else. I'm happy to answer more questions about that. The other thing that will routinely be done before you see the doctor is an eye exam. And I know you've all probably seen this chart very, very often, or many times in your life. It's called a Snellen chart. And as you can see, you know, where your child reads to, where your child can identify correctly the letters, can give us an idea of how your child's vision is. If the vision is worse than 20/40, she or he will not be cleared to play sports. So it's very important, you know, we recommend an eye exam at least once a year since the child starts to read. This is one of the ways that we do it, and it's very important to kind of adhere with that. Okay, so then I'm going to talk about what will happen once the patient comes in with you and talks to the doctor. So, you know, as pediatricians, what we do is something called the history and the physical. The history is the part where we're talking to you. And the part where we're talking to you is going to include a lot of questions, right? So what are the things that, you know, and every pediatrician does this differently. And I just want to give you an idea of like what you should expect for the doctor to ask, what you might want to bring up in case the doctor forgets to ask, which can happen. And just a general idea of what we consider to be part of the whole well child care visit. So the first thing that, you know, that I ask about is what's called an interval history. And what I mean by that is that theoretically, you know, for a primary care doctor, the physician has seen this kid every year, right? So I want to say, hey, I saw you last year around this time. Did anything big happen in between? Maybe they'll say, oh yeah, you know what? I broke my foot. Okay, that's important for a doctor to know. Maybe they'll say, oh, you know, I think she might have had an allergic reaction to X, Y, and Z. These are things that are really important. So when the doctor says, it can kind of be like a vague, generic question. And the doctor says, how have you been since the last time I saw you? These are things that as a parent that you might want to kind of think, oh, what the doctor's trying to ask me is how, was there anything medical that was going on? Then the doctor might ask something like, is anything bothering you? That's the complaints, right? So in medical school, we're taught that the first thing to ask about is a chief complaint. And I'm happy to go into more detail about that if there's any pre-med teenagers on here. But, you know, is anything bothering you? Maybe there's a rash that's been bothering you. Maybe your kid's been feeling a little bit constipated recently. Anything, really anything at all, anything that you want to tell the doctor. Then we'll always want to review medical history, allergies, medications that the patient's on. We always want to ask about dental care. So the recommendation is that a child sees the dentist every 6 months. Many kids do not see a dentist every 6 months, and that's okay. But that is the recommendation. That's the formal recommendation, and that's the best for dental care. We want to ask about if there's been any cavities. We want to make sure that your child is brushing his or her teeth twice a day, that she's flossing, and that there's a good source of fluoride. So if you live in New York City or in the surrounding area, there is a great source of fluoride in the tap water. In other parts of the country, there are not necessarily such good sources of fluoride. So, you might need to drink bottled water. For girls, we will always ask about period history. So we'll ask if the patient is getting her period, if it's regular, if it's painful, how the cramps are, how long she bleeds for. One of the things that we worry about, especially, and Dr. Hellmann is going to go more into this, but one of the things that we worry about in teenagers who just start to get their periods is that they might be bleeding too much. And in that event, there might be a risk of anemia, which means like a low red blood cell count, low iron count. So that's something that we monitor for. I always ask about diet. If you attended our body webinar, our body image webinar a couple of months ago, this is a hot topic, and it has the potential to be a hot topic. Ultimately, kids need to be getting a varied diet with basically every single type of food, and that is what I will try to emphasize if I'm seeing a child with an obese BMI, which means that the BMI is higher than the 95th percentile. I'll try to emphasize, fruits and vegetables and whole grains and meat, protein sources. Every doctor does this differently. So, you can know that this will come up, and there's a little bit of nuance. Definitely feel free to ask more questions, but the bottom line is that every kid should eat every single type of food, more or less. Bathroom habits. So is the kid really, I really wrote that to mean constipation. Many kids are constipated. This circles back to diet. A lot of times it's because they're not eating enough fruits and vegetables. It could also be because they have maybe not the best bathroom habits, and there could be a lot of other, or they might not be drinking enough water. So that's something that I will always ask about. Also, peeing is an important thing to talk about. We don't routinely ask about it, but if a kid asks, well, how much water should I be drinking? What I'll always say is that your urine should be relatively clear, pale yellow. Depression screen, I'm gonna circle back to that. Some clinics do offer a depression screen like before you see the doctor. Other clinics don't. So, but that's actually more in like the confidential portion of the visit. So I'll circle back to that for sure. And then physical symptoms. So I'm gonna ask, we go through what's called a review of symptoms, and I'm gonna ask, you had any headaches recently, fevers, notice any rashes or any muscle pain or any joint pain? Again, every doctor does this differently. So I don't want you to, I certainly don't want you to come away from this feeling that there's like a black and white way that this goes. But these are just things that I want you to kind of be prepared for as you enter the well child exam. Okay, so this is my favorite part. Every kid over age 12, by law, should be, their parents should be asked to leave the room when in these types of visits, so that the doctor can talk, or the provider can talk to the teenager privately. This is what we call a psychosocial assessment. Now, if you as the parent don't want to leave your child, that's not really okay, because the reason is because the child needs an opportunity to have a confidential discussion with the provider. If the child does not want their parent to leave, that there's maybe a little bit more gray area, right? So I want to be clear about that. We're not going to force a child to be in a room by herself with a doctor, but every child over the age of 12 years old gets offered this, and I would very much encourage and advocate children to take this opportunity, because even if there's nothing on the child's mind that maybe comes to mind, I always start off these questions by saying these private conversations by saying, hey, is there anything that you want to talk to me privately about? Almost every single kid says no. I don't have anything that I can think of. But then, I ask questions. So what do I ask? First I ask about the child's home life. I say, who do you live with? Do you have enough privacy at home? And you're going to hear as I go on, the child does start to feel a little bit more comfortable knowing that they're talking to me privately, right? So we always ask about the home environment. We ask about how the child's doing in school. We say, what grade are you in? We ask, do you have friends at school? We ask about what the child likes to do for fun. That's something that's really, really important because, and by the way, every pediatrician does this differently. I'm just telling you how I do it, but it's always important to ask what the child does for fun. One, because this is the age where kids start kind of really identifying what they like to do for fun, right? It's where they start. Adolescence is a period of really, really feeling like you're understanding, you're finding the things that bring you joy in life, and that's what's really fun to be an adolescent doctor is to watch kids kind of discover that. So it's fun for me, and I think it's fun for the kids to kind of talk about that. And the other reason why it's really important to ask a kid, what do you do for fun, is because I might be able to bring that up later, and I'm going to get to that. So I always ask about substance use. If the child's doing any drugs or alcohol, smoking, anything like that, these are things that are really, really important that in the religious world, they might not happen as much as in other parts of the world, but they do happen. And it is so much better to catch it than to not, and to avoid it. Similarly, I ask about sexual activity. So doctors will do this differently. And I know that this can be something that's very sensitive for, especially in the religious world. I know that this can be sensitive. It is depending on the age of the child and depending on how the previous, how the child is reacting to my questions. I will always at least ask, first of all, have you given any thought to if you're interested in boys or girls? Because this could be a safe place to talk about that. And I'll always give thought, and I'll always say, have you ever been intimate with someone? If they look at me like they don't know what that means, I say, for example, have you ever kissed someone? Again, I know we're here on the Jewish Orthodox Women in Medicine Association, right? I know that there is an awkwardness to this, and I want to recognize that. But these are questions that if the doctor doesn't ask them, then who will? So it's really, really important. Similarly, I will always ask, did you ever feel pressure to do anything that you didn't want to do? And that's really important. That's really important to ask. Most children will say no, but some children will feel so grateful that they had somebody to ask. Finally, what I ask about is mental health questions. So that's getting back to the depression screening. I always open, we say, oh, how's your mood generally? And again, this is still confidential. This is still just me and the patient in the room. I say, how's your mood? I say, what do you do when you get sad? I'm trying to assess for coping mechanisms because adolescence is, of course, the time where when a kid was younger, what they might have felt as sad or as, kind of like distraught it might have been a little bit more of like it might have been a little simpler of a feeling. In adolescence, that becomes a little bit more serious, a little bit more heavy, right? So I'll ask, what do you do to cope? This is where I can bring back the things that the kids like to do for fun. And I will always, always, always screen for self-harm and for suicidal ideation and for homicidal ideation. So the idea is thinking of killing oneself or thinking of killing or hurting others. Again, this is a completely confidential part of the history. And because I know that there are some teenagers on here, you know, the one thing that a doctor cannot keep confidential is if a patient says that she or he is planning to hurt herself or others. And by hurt, I really mean like close, you know, severely hurt. So these are things that do have to be disclosed so that way we can keep everybody safe. Okay. Again, I am happy to answer more questions about these. I know that it's a heavy topic. All right. So now I'm going to switch gears a little bit. I'm going to talk about the physical exam. So a couple of things. So first of all, you know, we always listen to the child's heart and lungs, feel the stomach. Typically speaking, these are normal. These parts of the exam are normal. Sometimes you might hear what's called like a benign murmur. Many children, not so many adolescents, but some have what's called like a healthy benign murmur. If this is new, then it will probably warrant a cardiology referral. When I listen to the patient's lungs, I sometimes am listening for wheezing or for other, you know, for signs of asthma or maybe allergies, but usually the lung exam is normal. I always look in the child's mouth to look for any cavities that the child might have, and to see their dental health, their gum health. I always look at the nose, make sure everything's clear, see if they have any allergies in their nose. We look at the ears. Oftentimes there's wax in it and we can't see anything, but as long as the ears aren't bothering them, we don't do anything about it. We check for rashes, eczema. This is a picture of eczema over here. Eczema is a very, very common thing that we see in teenagers. So, we'll try to evaluate that. Sometimes it warrants a dermatology referral, not always. We check for scoliosis. That's when the doctor asks you to, put your feet together and bend over, touch your toes. You don't have to touch them. You could just bend over as much as you can. And then we assess for range of motion, because a lot of you are coming here for sports physical. You want to start playing, you want to play sports. Your paper is signed to say that you could play sports. So we assess for range of motion. And we do that, in different ways by getting you to move your legs in different ways. Okay, so sports participation. This is not everything that goes into the signing of the sports participation exam, right? However, I'm just going to kind of talk about the biggest things that might come up. So one is asthma. A lot of kids have asthma. Asthma will not preclude you from playing sports, but it has to be well controlled. So if you need to take your inhaler before you play, you have to do that. If you're supposed to be taking daily medication for your asthma, you have to be doing that, because otherwise it's not safe to play. Blood pressure. A lot of kids, this is not an issue for. Some kids do have higher blood pressures. In order to preclude you from playing sports, the blood pressure has to be above a certain amount. And again, that number changes depending on the child's height and age. But if it is elevated, then what we'll say is, we need to see you back in a couple of weeks and take the blood pressure again. If when you come back, the blood pressure has corrected itself, maybe it was just because you were nervous that time. So that's something to keep in mind. There's a huge, and if you came to our body image webinar, you would probably know, there's a huge epidemic of eating disorders right now. So when I'm clearing somebody for sports participation, I will always look at their weight. And more importantly, I'll look at how they're growing. So how they've been growing their whole life. And if they suddenly have either lost weight or they haven't gained weight in the way that their previous growth indicates that they should have, meaning they were growing on a certain curve and they fell off of that curve, I'll say, hey, you know what? We have to look into this further before I clear you for sports. Vision. So children, like I said, if your vision is worse than 20/40, you will need to get glasses and get corrected vision before anybody can clear you for sports. And then musculoskeletal issues. So if you had a wrist fracture last year, I need to see an orthopedics clearance. If you are not able to do some of the range of motion testing, I need to, kind of figure out what's going on with that. So that's important. Okay, blood work. Do you have to get your blood drawn? Sometimes. So the recommendation is at least twice during adolescence, you need to have what's called a lipid panel, which is really like getting cholesterol levels and things like that. But sometimes if there are other risk factors for high cholesterol, we will draw it more than just twice. We'll do it once a year, or maybe even more. Also, we want to take a look at how your red blood cells are. So for girls, especially who are getting their periods and bleeding regularly, this might happen more than, it might happen kind of closer to once a year versus once every few years. Every doctor is different. Every doctor does it differently. And obviously it depends on the patient, but these are things that we look for. And then finally, vaccines. So Dr. Hellmann is going to talk more about the HPV vaccine, but in adolescents, the other vaccines that you will get are something called the Tdap. So that's the tetanus plus other things. And it's kind of the follow-up of the series that you got when you were a baby. If you get later a dirty, like cut or something, like, if you stab yourself with a rusty porch chair or something like that, you might get what's called a booster. That's very situational. But that's when you hear people say, oh, do you need a tetanus shot? That's what they're talking about. It doesn't contain the diphtheria and acellular, or it doesn't contain the pertussis. It just contains the tetanus and the diphtheria. There's also 2 meningitis vaccines. That's what's meant by meningococcal. So there's this first one is pretty much required by like most schools, and is certainly required before a kid goes to like seminary or to college, and is living in close quarters. This meningitis type B vaccine is not required typically, but it's very, very recommended. So it's, I highly recommend it. Meningitis, any bacterial meningitis, which is what these are protecting against, are extremely dangerous diseases. So we really, really do recommend it. And then seasonally, the COVID vaccine and the flu vaccine. The flu vaccine you get yearly, and absolutely kids should get it. Really, if you have babies under 6 months living in the house with you, everybody should get it. And if you have elderly people living in the house with you, everybody should get it. The COVID vaccines, there's obviously ever-changing recommendations, but boosters did just become like this year booster did just become recommended by the CDC. And I think that's the end of my presentation. So thank you all. I hope that was comprehensive and not too overwhelming. I'm going to stop sharing my screen. Please, please, please feel free to write into the Q&A. And I'm so excited to hear from Dr. Hellmann.
All right, thank you so much, Dr. Gutman, for giving us the rundown on teen health. Our next speaker is going to be Dr. Mira Hellmann-Ostrov. Dr. Mira Hellmann-Ostrov is a board-certified obstetrician and gynecologist, and she specifically specialized in GYN oncology. She received her medical degree at SUNY Downstate University Medical Center with a lifelong membership to the AOA Honor Society. She completed her residency training in obstetrics and gynecology at Long Island Jewish Medical Center and her fellowship training in GYN oncology at SUNY Downstate in Brooklyn. Dr. Hellmann's career has been focused on academics. She has taught medical students and residents. She currently works at the John Farrar Cancer Center at Hackensack University Medical Center and is an assistant professor at Hackensack Meridian School of Medicine. She serves on the residency review committee. She is a specialty clinical instructor for minimally invasive surgery. She's a certified intuitive instructor and instructs other surgeons in robotic surgery and functions as a surgical consultant for Ethicon. She's very active in research and is a primary investigator on several research projects. She enjoys helping the community through outreach, and she previously was one of the on the JOWMA board of directors. So without further ado, we're going to start with Dr. Hellmann's presentation. Let me just go ahead and share the screen. Give me one moment. All right, so from the very beginning, just bear with me for one moment. Okay, is everyone able to see this? Yes, okay, perfect.
Good. Thank you, Dr. Benayoun, for that very lengthy introduction. I was going to play the Grammys music there for a minute. I didn't realize how long it was. But it's my pleasure to be here tonight. Big footsteps to follow after Dr. Gutman's presentation. My talk is going to be slightly different. As a gynecologic oncologist means I am a gynecologist, but I specialize in treating women's cancer. My focus is a little bit more in terms of treating diseases and preventing bad diseases that I see in my practice. And that's what I try to integrate into my talk, and I hope I can relay to everybody here to emphasize the importance of preventing of intervening at this point in adolescence to prevent further issues and complications as people get older. So this is just an introductory slide, and here this just means that there's nobody influencing my discussion. Oh, you skipped the non-disclosures. Okay, so just to go over some female basic anatomy. This is internal reproductive organs. This is what all girls and women have internally. As you can see, unfortunately, I apologize. I can't use the pointer here because my Zoom link is not very, there's something wrong with it. So I have Dr. Benayoun sharing my slides for me. But if you look in the center, the triangular shaped structure is called the uterus. The inside lining of the uterus is called the endometrium. The uterus is basically like a collapsed balloon. It has a cavity inside. Inside that cavity is where a fetus or a baby grows and develops. Attached to the uterus on either side, you have these tubular structures called fallopian tubes, and their ends are somewhat attached to these round structures called ovaries. The ovaries produce the eggs, also known as oocytes, which get released into the tube. And the process of forming a fetus or a baby actually occurs into the tube, inside the inner part of the tube, and then goes into the uterus where it implants itself and it grows and develops into a baby. So that's just a basic lining of the anatomy, and the tubular structure leading to the uterus is the bottom of the uterus known as the cervix. And the cervix feeds into a cavity known as the vagina, which is the canal that leads to the uterus and cervix. We can go to the next slide. This is a side view of female pelvic anatomy, and just to explain so everybody knows where things lie in their body. This is looking from the side. You'll see towards the left side is, and blue is like this collapsed balloon. This is the bladder. That's where the urine accumulates and then someone goes to the bathroom to urinate. Directly behind it is the uterus, which we talked about. That's the female reproductive structure. And behind that would be the rectum, from where the stool is produced and people have a bowel movement. So as you can tell, all these structures lie very close to each other, And that's important to understand because when you're getting your period and you're having cramps, sometimes you may have some problems going to the bathroom or some difficulty with urinating or going to the bathroom hurts. And this is part of the reason why, is because anatomically, these things sit very, very close to each other. Next slide. So going to the basics, what is menstruation? Just so everybody understands, menstruation, also known as someone's period, is basically once a month, the lining inside the uterus, which we talked about earlier, sheds. And that causes bleeding, and that's known as a menstrual cycle or a period. The period is brought on by various fluctuations of substances in the body known as hormones. And those things go up and down in a normal cycle and lead to the shedding of the lining of the uterus. These menstrual cycles or periods occur once a month. On an average, it's every 21 to 35 days. That's called normal. And the average is every 28 days. Girls in the United States usually start getting their periods or their menses at ages 12 to 13. Although in some groups of people, it can start as young as the age of 9 and actually can go up to the age of 15 to first get your period. But this is averages that we're talking about. Next slide. So that's the normal, what I briefly talked about is what a normal period is once a month. You shed the lining of uterus and you bleed. And the way that someone doesn't get their period is if they become pregnant and then the lining of the uterus doesn't shed and then you don't get a period, which everybody knows. But that's the basics of a normal menstrual cycle. When someone starts getting their periods, though, it may really not follow that regular pattern of every 28 days or every 21 to 34 days, and may be quite irregular for the first 2 to 3 years after someone starts getting their period. So if someone's 12 and their periods are sort of very not regular, it's nothing to be alarmed about because that's completely normal for the first 2 to 3 years of getting your period until the body regulates itself and gets into a normal cycle. But after 2 to 3 years, if the bleeding pattern becomes abnormal, that's something that should be mentioned to your regular visit with your doctor that Dr. Gutman was talking about. She touched on this briefly, and I want to explain it in a little bit further detail. Next slide. So to go over what would be considered an abnormal period or something that should be brought to the gynecologist's attention. First off, if someone who has not had a period within 3 years of showing growth of hair in areas of puberty development, showing growth of hair and puberty development in areas that weren't there before, such as hair in the armpits or hair in the pubic area. Another thing to be brought to the gynecologist's attention is if the periods have not started by the age of 14 and 15, or 15, usually 15, but 14 in some special circumstances. If the periods are very, very irregular after the first 2 to 3 years, for example, if the periods are coming every 2 weeks, or if someone was getting regular periods and then they did not have their period for more than 90 days, those are things to alert the gynecologist to, or the pediatrician to that you're seeing at your adolescent visit. If the periods are very, very painful to the point where you can't go to school, you can't play with your friends, you can't get out of bed, this is something that needs to be brought to the pediatrician's attention as well. And if the periods last longer than 7 days, again, more concerning if this is after the first 2 to 3 years of starting menses. Next slide. Now here's a list, which is, I'm not going to get into the details of this. We're going to focus on a couple of things here just to bring it to your attention. But there's a whole long list of things that can cause periods to be irregular. And one of the top things on the list is plain and simple stress and lifestyle factors. So I don't want anybody to be alarmed and say, oh, my periods are not normal, there's something really wrong with me. That's not necessarily true. It could be various things going on in someone's life, various stressors. Everybody knows that people go through hard times, and this can really affect someone's period. So it can be a very normal part of what's going on in life, but again, still needs to be brought to your pediatrician's attention. And as we can go down the list, but there are various things that can also cause period changes, and those are important to pick up on and address, which is why this needs to be brought to the pediatrician's attention so it can be fixed to prevent problems down the line. Next slide. One of the conditions that can cause irregular periods is known as polycystic ovarian syndrome. If you go back to the previous slide, you'll see that that's listed number 1, 2, 3, 4, 5, 6 on the line. These aren't necessarily in order of frequency or what causes period problems, but it's an important one, and I'll explain to you why. Let's go back to the next slide. So what is polycystic ovarian syndrome? Polycystic ovarian syndrome is defined as a common condition that affects hormones. This is all hormonally driven, and it causes irregular periods. It causes excessive hair growth and acne, so lots of pimples. And one of the bigger problems with it is that once someone is trying to get pregnant, it can cause problems with getting pregnant and having children. Next slide. So a couple of facts about polycystic ovarian syndrome. It is the most common disorder of hormones. Endocrine basically means hormones in our talk. It is the most common problem with hormones in young adults. 1 out of every 10 women in the United States are thought to have some mild form or some form of polycystic ovarian syndrome. So it's fairly common. It can present in various ways that affect the body. One that we're focusing on today is the ability to have children down the line, otherwise known as reproductive. Another way that it affects people is metabolic. It can lead to other problems down the line, can be associated with diabetes and other long-term health problems down the line. And as we mentioned earlier, it can also affect the skin. It can cause a significant amount of acne. And it can be to various degrees in people. Some adolescents have a small component of it, some have all the factors of it. So it's a little bit tricky that it doesn't present the same in everybody. But we're not going to get into these details. There are strict criteria used in order to diagnose this. Next slide. These are the criteria. They're called the Rotterdam criteria. And this is one of the ways. There are a couple of ways to diagnose it, but this is one of the ways to diagnose it. And just to explain to you where the term polycystic ovaries come from is that not always, but oftentimes, women will have a lot of tiny little water bubbles, essentially called cysts, on their ovaries. And these black and white pictures that you see on the bottom are little, you see these little circles, these little black circles, those are all the little water bubbles around the ovaries known as cysts. So this is kind of what an ovary looks like in someone classically who has this condition. Next slide. So we said, one of the things that's concerning about polycystic ovarian syndrome is that down the line, it can cause problems getting pregnant. It can also go the other way. People can release a bunch of eggs at the same time and have twins and triplets unintentionally, which I know sounds cute to everybody, but sometimes it's not so cute and very hard to deal with. And long-term, which is something that's personally something that I see unfortunately, is that if the periods aren't regulated, and if this polycystic ovarian syndrome goes and no one pays attention to it and nobody treats it, when someone gets older, it can lead to cancer inside the uterus. Next slide. Luckily, though, there are treatments available for it, and it can be very easily treated. The best way to treat it is to simply get the periods under control and regulate them so that they occur at regular intervals, either once a month or once every 3 months. But the point is that it's regular and that it's controlled. One way to do that is with a group of medication called birth control pills. Now, I want to tell everybody that this term birth control pills, in my opinion, is a misnomer. It really should be called hormone control pills, because it is used for many, many things aside from just preventing pregnancy. But the commonly known term is birth control pills, and those can be used to easily control and regulate the cycles so that people don't develop the secondary problems related to the polycystic ovarian syndrome that we talked about, the infertility, the abnormal bleeding, the potential to developing cancer. Another way to treat it is if someone's trying to get pregnant and they can't, is to use a medication that helps release the eggs to allow pregnancy, known as Clomid. And lastly, something to consider in someone who maybe has a very bad case of it and it's hard to get under control, is to undergo a procedure where the eggs are saved for later, where they could be used to help someone get pregnant. It's called egg freezing or oocyte cryopreservation. Next slide. So that's a basic overview of one of the most common conditions called polycystic ovarian syndrome. The other condition related to abnormal periods that I wanted to talk about is called endometriosis. So the definition of endometriosis is an often painful disorder in which tissue similar to the one that's inside the uterus can escape the uterus and cause very, very painful periods. So the hallmark, meaning the most common things that is seen with this disorder, is that people experience very, very painful periods. And we sort of talked about that earlier, that this needs to be discussed with your pediatrician or adolescent gynecologist or whoever you're going to see for your regular visits, because very, very painful periods can be a clear indication of endometriosis. It could be either very painful periods, severe pain in the back during periods, pain during intimacy, extremely heavy bleeding during periods beyond what is normal, or even a little bleeding between periods, which is not normal. Down the line, endometriosis can also present as inability to get pregnant or extreme difficulties in getting pregnant. And it can affect other organs, like we saw on the slide earlier. Because these organs are close to each other, it can affect bowel movements, it can affect going to the bathroom, it can affect urination. So all these things can be affected by this condition known as endometriosis. Next slide. So aside from having painful periods, what is the problem with endometriosis? One of the biggest problems, and again, we're talking to a group of Orthodox young females that may or may not plan to have a family in the future and have children, but it is something that is common in our circles. Endometriosis can lead to infertility, which means it can lead to difficulties getting pregnant when someone chooses to have a baby. It also causes pain, as we discussed earlier. Again, I know I'm kind of repeating myself, but I want to emphasize this: problems going to the bathroom, urinating, and having bowel movements. And in extreme conditions can cause problems even with the kidneys and the lungs. Next slide. So luckily, endometriosis is something that, if recognized, can certainly be treated. Number one, and most importantly, is to control the pain. The medication that helps the most with the pain related to endometriosis is a group of medication called NSAIDs. That's your Motrin and your Advil and ibuprofen. Those type of medications help the most with these severe painful periods. And if it's brought to your pediatrician or gynecologist attention, they can, if you're given a prescription dose of the Advil or the Motrin, that can be taken just on those really, really bad days so that pain is controlled. The other class of medication that can help a lot with this is known, again, the birth control pills, or let's rename them hormone control pills, that will help regulate the periods and will help this condition to be brought under control. There are other ways to manipulate hormones aside from these kind of pills that can be used as well to sort of suppress periods from happening altogether, but that's in more extreme conditions. And lastly, surgery is a very effective way of treating this condition, but is usually left as sort of a last resort when the endometriosis gets really bad and can't be controlled with medication. Next slide. So those are the two conditions I wanted to highlight, because when you go to your pediatrician or you go to your adolescent gynecologist, I don't want these things of painful periods to be like, oh, that's normal, everybody has that. Or irregular bleeding being like, oh, that's normal, everybody has that. just because a lot of people have it does not necessarily mean that it's normal. And it really should be addressed, because if treated, can save a lot of problems down the line. The next thing I want to discuss briefly is vaccines is wrong to be vaccine in adolescents. I want specifically to talk about what's called the HPV vaccine. Some of you may have heard this from your pediatrician, some of you may have not, depending on where you see your doctor and what communities you're from or what area that you're from. But it is really a very important vaccine that is recommended both by gynecologists and pediatricians to be given universally to all adolescents. HPV is a little virus. Everybody has this virus pretty much at some point in their life, somewhere in their body. It causes warts on the fingers, it causes various things in other places. And it's a really big family, this HPV family. It's sort of like a nice big Greek or Jewish family, has over 100 strains, and they're all cousins. But there are some particular groups or subsets in the families that can cause real problems down the line. What are these problems? Next slide. Unfortunately, in the extreme case, these group of HPV viruses can cause cancer in people. And it's not as rare as someone would think. About 45,000 people in the United States a year are diagnosed with a cancer that's caused by this virus. Next slide. Luckily, we've developed a vaccine to help prevent these viruses from causing these cancers down the line. There is a vaccine known as Gardasil, which protects the body against 9 of these HPV families. And it covers most of the families that cause cancer in women. Next slide. Now, just to explain specifically what we're talking about, it causes various types of cancer, but as a gynecologist, what we see is that it can cause cancer in that little area on the uterus called the cervix. Dr. Benayoun, if you can quickly just go back to the first, the anatomy slide for a second. Apologize, just to remind everybody what that is. So the bottom of the triangle is this sort of barrel-shaped structure. It's known as the cervix. So this virus can cause cancer in that particular anatomical area. Thank you. Okay. Now, to give you an idea of how important this is, okay, what this diagram is basically showing is these are various vaccines that people get, adolescents receive to prevent conditions from happening. I want you to look on the right. You see how this bar is the highest? Okay. That is for this vaccine against HPV, meaning that this vaccine can prevent such a common thing. The bar is the highest, meaning that it happens most commonly in adolescents. So it is a very, very important vaccine because it can help a lot of people because it's a very common condition. Next slide. And just it translates into how people are affected down the line. As you can see, it has a very high graph, just meaning it can save a lot of lives. Next slide. So how is this vaccine given? What's the recommendation? We really want to give it when someone is young and their immune system is very, very active because it helps build a very strong protection against this virus. So the recommendation is really to give it before the 15th birthday. And if you get it before the 15th birthday, you save yourself a shot because you only need 2 shots. And the shots are given, there's 1 shot, then you wait 6 months, then you get the 2nd shot. But if someone's older than 15, because the immune system doesn't build such a strong army after that point, maybe as earlier, you actually need 3 shots to get the same level of protection. So you get a shot. A month to 2 months later, you get another shot, and 6 months later, you get another shot, 3 shots. And then someone who has a weak immune system to begin with, 3 shots is recommended across the board. So this is just a general recommendation. Now, I know time is coming to an end and I don't want to belabor this, but I do want to emphasize, next slide, please, that all this mumbo jumbo on the screen basically means this vaccine has been studied in many, many people, in millions, literally millions of women who've received this vaccine, and it is extremely safe. It doesn't cause problems with periods. It doesn't cause problems with pregnancy. It doesn't cause long-term effects, meaning it's very safe. Next slide. This is basically just saying the same thing. Unfortunately, there are a lot of rumors surrounding vaccines sometimes, and this vaccine's no different. But this vaccine has been very well studied worldwide over more than a decade, with millions of women, and has shown to be a very, very safe vaccine. Next slide. I wanted to thank you all for listening. I hope this was helpful. I hope this is something that gives you something to think about when you go to your next checkup, and just like, okay, match the belly, check the anatomy, make sure everything's okay. If there's any of these things that are bothering you, please bring it up with your pediatrician or your adolescent gynecologist. Next slide. And this is my little pride and joy. Have a good night.
All right. Thank you so much, Dr. Hellmann-Ostrov. We thank you for your time, for your very comprehensive presentation. If anyone has any questions they would like to ask them in the Q&A box, again, you're welcome to enter them anonymously. Otherwise, one question that I had was really could be addressed to either Dr. Gutman or Dr. Hellmann about heavier periods. How does a teenager know if her period is quote unquote heavy?
I'll answer unless you really want to, Dr. Hellmann.
Go ahead.
I'm going to take the stage. Yeah, so it's a great question. The short answer is that there's really no way to actually know. We often ask kids, how many pads are you going through a day? Are they fully soaked? So, over like 4 fully soaked pads a day might be an indication of what's called a too heavy period. But really, the thing that matters is A, is it bothering you? And B, are you anemic? So are you losing too much blood? So we would have to get blood work to understand if there's too much blood loss from like an anemia perspective. And if it's bothering you and it prevents you from, let's say, playing sports or going to school or anything that's kind of part of like a regular teenage life, then it's too heavy. And we would want to treat that.
Dr. Gutman, thank you. I was having connectivity issues. I apologize. But I agree with you 100%. The strict definition of too heavy bleeding is exactly like you said. Going through a maxi pad every 2 hours is too heavy for a period.
But having said that, a lot of kids change their pads very frequently and they're not fully saturated. That's fine. That doesn't mean anything, and that's fine. That's just your choice. Yeah. Correct. We have a question. When prepping a girl for a period, what does the doctor recommend them have in their bag? Oh, that's a great idea. So I would definitely recommend, to bring pads. The other thing that I always did when I was a teenage girl getting my period for the first time was I brought like a paper bag because I was a little bit embarrassed that people might, see the pad in the garbage can. That is obviously very silly and not necessary, but it made me feel better. So that's something that I did. But pads, tissues, extra pads, that's it. I would say just go over with your child, how to use a pad.
And maybe an Advil.
And an Advil, yeah. Oh, that's a good, did you say this, Dr. Hellmann? So Tylenol doesn't work for period cramps. Yeah.
We went over.
You went over that. I apologize. Sorry.
Okay, no, I agree. I think that needs to be driven home. Tylenol is not going to help.
Yeah, so always
Motrin, Advil.
It has to say NSAID on it, yeah.
Naproxen also works really well.
right, which is illegal.
Okay. Anybody else have any further questions? Looks like nothing for now. So just as we conclude, we just want to remind everyone that JOWMA is a free community resource. It's a nonprofit organization. All of our content is paid for through grants, through sponsorships. But if anyone should choose to want to contribute, I did post the information in the chat box. And yeah, thank you everyone for joining us today. We hope that this was a helpful and informative session. If anyone has any questions or feedback, you can email teenhealth@jowma.org. I'll also provide that information in the chat. That can help us tailor our content so we can provide even more relevant teen education like this one throughout the year. We also want to remind everyone here that we are having a part 2 next Sunday at 8 p.m. Eastern time. This will be geared towards teenage boys. So Dr. Hellmann will not be with us, but Dr. Gutman and I will be around as well. So it is a separate Zoom link and you need to register separately. You're not automatically registered if you register today. But again, this is for caregivers of teenage boys. We also want to thank the Jewish Press for recognizing the importance of our work and helping us spread the word about this specific webinar. And as always, a special thank you to the team at JOWMA. So that includes Dr. Alyssa Minkin, Dr. Mimi Knoll, Dr. Sharon Stoll, Hadassah Stein, Shoshana Lunzer, Brendan Newman, Miri Korlansky, and Onit, our administrator. So thank you again. If anyone has any further questions for panelists, you are welcome to email teenhealth@jowma.org. And thank you for participating. Have a good night, everybody.